And now we are going to speak a little bit about imaging more in detail. So why? The first thing is that when we use imaging, we have to understand what are the questions that we want to put to IVUS or to OCT. So the questions are, do we need something to modify the calcium? Which tool should we use to modify calcium? And was calcium modification successful? In order to avoid what Damiano showed us in the previous presentation. So first of all, we have to understand that calcific lesions are very complex also to interpret, and we may have less severe calcification and going up to more severe calcifications. And of course, there are a lot of patterns that we can evaluate or even measure in order to give and grade the lesion, the calcification extent. So for example, we may have mild calcific lesions when we have a small arc of calcium, when we have thin calcification, when calcium is intimal or superficial, and when the length of the calcifications is short. And then we can grow with more diffuse eccentric calcifications that overcomes 180 degrees, or when we have nodular calcifications. Or again, we may have severe calcium when it is concentric or circumferential, when it is thick, when it is deeper, and when it is long. And at the end, we may also have uncrossable lesions where calcifications made no device able to cross the lesion. And this is another important slide, which is very elementary, but need to be stressed. If we use imaging, we should use it at least 3 times per lesion. It means that we need to use IVUS or OCT before intervention in order to assess plaque composition, for example, identify the reference vessel diameter, so take measures of the healthy vessel, and also choose stent size, stent length. Again, we should use imaging after lesion preparation because we want to be sure that our preparation was successful, and we need to do imaging to assess if the calcium has been, for example, broken, if landing zone have changed or not, and if we think that our strategy is ready for stent delivery. And at the end of the procedure, again, we should use imaging to assess the possible problems with stent under expansion, deformation or malapposition, and also to identify edge dissections and rule out any geographic miss. So this need a stepwise approach with the pre-interventional assessment, then lesion preparation with different tools that we can use, and we will see them in the next lecture, and also to see the result of our plaque preparation or our lesion preparation, and at the end understand if the stent is well positioned. So what about pre-interventional assessment? Let's focus first on the first 3 images which can be measured. So this is a quantitative analysis that we can do on IVUS about length, angle, and thickness. So you probably know there are some calcium scoring. This is the OCT-based calcium scoring that identifies complex lesions with a scoring grade that take into account the arc of calcifications, the thickness, which if it is more or less than 0.3 millimeters, the length, if it is more or less than 3 millimeters when the arc is more than 270 degrees, and we can grade it from 0 to 3 point, and if we have 2 or 3 points, we recommend the preparation. But you can see also on the right-hand side of the slide also one of the algorithm. This is the algorithm from De Maria, which tells different measures, and these measures are based on IVUS, which is a little bit different from OCT. So we take into account again the circumferentiality of calcium, the presence or not of calcified nodules, the vessel diameters, but also the length of calcium more than 5 millimeters or less than 5 millimeters, and the thickness of calcium. So all these patterns can be evaluated with IVUS and or OCT and can be measured. And it is very important when we look at IVUS not only to focus on the slice, on the axial images, but also focusing on the longitudinal images that you see here in the bottom part of the slide, because one important thing is to measure the length of calcium, as we said, and this can be done only if we use an automatic pullback. And you can already have an idea by looking at the longitudinal view of IVUS if calcific lesions is focal or diffuse, like in this case, but you can measure very, very precisely if you use an automatic pullback. So what about calcium thickness? Somebody say that to measure thickness you need to use OCT, which is completely true, because OCT can really measure the thickness of the calcific plaque. But it is possible also to differentiate thin or thick calcium with IVUS. And you can see here two images that have a calcific lesion, but there are some differences. And these differences are reverberation. So when you see this kind of reverberation that you see, like the image looks concentric, this means that the superficial calcium is the surface of calcium is very flat, and this usually is associated with thinner calcification. So if we see this reverberation, we may say that this calcium is thin. If we don't see any reverberation, for example, in this image we have reverberation on this side and no reverberation on this side, probably this calcium is thicker than this one. And this is also been evaluated with a comparison with OCT, and when we have an irregular surface without reverberation, we usually have thicker calcifications. And this is a comparison between IVUS and OCT images of the same vessel with thin calcifications that is evaluated with both systems. And this again is another image where you can see that there are no reverberation here, and there is a very thick 1.5 millimeters thick calcification on OCT. Again, we can measure calcium arc. We can divide our artery in 4 quadrants, 90 degrees each, and we can measure the degree, the angle of calcification. You see the shadowing here, and this is an 80, more or less 80 degree quadrant angle, so it's 1 quadrant. And in this situation, we have a much wider calcium arc, which is 250, 270 degrees, which corresponds to 3 quadrants. And as we said, calcium length, which can be measured with an automatic pullback very, very precisely. If you combine your axial images and your longitudinal images, you can also have an idea of the volume of calcium. So probably we will have tools that will define the volume of plaque. We already have some of them, but also in calcified lesions that will tell us the volume of plaque, the volume of atherosclerosis, that we can do with CT scan by using intravascular imaging, and this may probably address more specific treatment. So, for example, if we see these two lesions, they look very similar, but if we measure them in the longitudinal axis, we can see that here we have a longitudinal calcification of 4 millimeters, without any calcified nodules. The vessel diameter is 4 millimeters, and there are reverberations, so it looks a thinner calcium. So the IVUS calcium score is 0. In this case, we have a longer calcific segment with more than 5 millimeters, no calcified nodules. The vessel diameter is less than 3.5, and there are reverberations. So in this case, due to the diameter and to the length, the calcium score is 2. And when we have 2 or more, we need something to modify the plaque or to debulk the plaque. And we go to the end, towards the end of this lecture, talking about morphology, which is a qualitative assessment of the calcification. So we said that we can measure a lot of things, but also we can see if the calcium is circumferential, is eccentric, if it is deep, and also if we have nodules, like in this case, because they affect long-term and also short-term outcomes. We have to differentiate between a spotty calcification, like in this case, and the nodular calcifications, like in this case. Nodular calcifications are more difficult to treat, as you probably know, and nodular calcifications are calcifications where with a convex luminal surface that can be easily identified with imaging. So the take-home messages of these lectures are that we have to use imaging to understand the burden of our calcifications and also to inform and to address our strategy. We have something that can be measured, and we have also a lot of images that can be addressed in a qualitative way, and this helps ourselves to give a better treatment to our patient. Thank you.